So my today's class is a vertical integration class of surgery with biochemistry. So I have given a case scenario, and the case scenario is a 62-year-old female from Thrissur has come with history of yellowish discoloration of eyes and urine for the last 2 weeks. She also has generalized pruritus. She also complains of fever with chills for the last 2 days. On examination, she has jaundice and tender smooth hepatomegaly. No other mass or free fluid is seen in the abdomen. That is the case summary. So, the problem is jaundice with tender hepatomegaly, but no palpable gallbladder and fever with chills. Jaundice can be prehepatic, hepatic, or posthepatic jaundice. Hepatomegaly. On examination, hepatomegaly is there, but there is no palpable gallbladder. Then in the history, there is fever with chills. So the clinical diagnosis would be obstructive jaundice with cholangitis. So here, my part is the biochemical investigation done to establish the diagnosis of obstructive jaundice. Biochemical investigation, both blood and urine tests to confirm the diagnosis of obstructive jaundice and to differentiate it from other types of jaundice. So, case scenario is that of obstructive jaundice with cholangitis. In biochemistry, we perform the investigations both in blood and urine to confirm the diagnosis and to differentiate it from other types of jaundice. The biochemical investigations are in blood. The estimation of serum bilirubin is done. You will be knowing the normal value of serum total bilirubin is 0.2 to 1 milligram per deciliter. Of this, the unconjugated bilirubin. Unconjugated bilirubin is the bilirubin which is bound to albumin. Unconjugated bilirubin is also known as indirect bilirubin. The unconjugated bilirubin, the normal value is 0.2 to 0.7 milligram per deciliter. And the conjugated bilirubin. Conjugated bilirubin is the bilirubin which is conjugated with UDP glucuronic acid to make it water soluble. That is the conjugated bilirubin. Conjugated bilirubin is also known as direct bilirubin. And the normal conjugated bilirubin level is 0.1 to 0.4 milligrams per deciliter. So total bilirubin 0.2 to 1 milligram per deciliter. Unconjugated bilirubin 0.2 to 0.7 milligram per deciliter. And conjugated bilirubin 0.1 to 0.4 milligrams per deciliter. The bilirubin is estimated in serum using the principle of van den Bergh reaction. The van den Bergh reaction is diazotized sulfanilic acid. Diazotized sulfanilic acid is the sulfanilic acid in HCl and sodium nitrate. So, diazotized sulfanilic acid react with bilirubin to form a purple colored complex, that is azobilirubin. So, when we mix the serum sample with the reagent is diazotized sulfanilic acid. a purple colored azobilirubin will be formed. So the intensity of color will be proportional to the amount of bilirubin which is present in the serum sample. We are measuring the intensity of the color to estimate the amount of bilirubin. When the bilirubin is conjugated, the purple color is produced immediately on mixing with the reagent. That is Vandenberg direct positive reaction. The conjugated bilirubin may be monoconjugated or diconjugated and delta bilirubin. All these bilirubin react with Vandenberg reagent and immediately the color is formed on mixing with the reagent. So that reaction is called direct positive. If the bilirubin is unconjugated, the color is obtained only on addition of alcohol. Alcohol which we use is methanol. So the bilirubin has to be solubilized using methanol. Only after that it produces the color with diacetized sulfanilic acid. So that reaction is called indirect positive. So unconjugated bilirubin gives indirect positive reaction. And if the serum sample contains both conjugated and unconjugated bilirubin in increased amounts, when we mix with reagent, the color will be produced immediately, and when we add the solubilizing agent, the color is intensified, and that is called biphasic reaction. So in obstructive jaundice, the bilirubin increased will be predominantly conjugated bilirubin, and we will get a direct positive reaction. It's a type of jaundice in which unconjugated bilirubin is increased. That is in prehepatic or hemolytic jaundice, the reaction will be indirect positive. In hepatocellular jaundice, both conjugated and unconjugated bilirubins are increased. So a biphasic response is obtained. So when we perform the Vandenberg test, the total bilirubin is estimated using the methanol extracted fraction. The direct bilirubin is the aqueous extracted fraction, and indirect bilirubin will be total minus direct bilirubin. So in the case scenario of obstructive jaundice with cholangitis, Vandenberg test will be direct positive. In our clinical biochemistry laboratory, the total bilirubin is estimated by Whitrow's total bilirubin microslide method. We are using the reagents in a dry form in the slides. So it is the microslide method. Total bilirubin microslide method measures the total bilirubin. So the total bilirubin include conjugated bilirubin, unconjugated bilirubin, and the albumin-linked delta bilirubin. All these fractions react with diazonium salts to produce azobilirubin chromophores. So the total bilirubin is estimated by modification of this Vandenberg reagent in the microslide method, and the same azobilirubin chromophores are formed, and from the intensity of the color we are estimating the amount of total bilirubin. And the conjugated and unconjugated bilirubin is measured by a separate method, that is again the microslide method. It is Whitrow's BUBC microslide method. And that is based on the principle that at 400 nanometers, both conjugated and unconjugated bilirubin have similar molar absorptivity. But at 460 nanometer, unconjugated bilirubin has a higher molar absorptivity than conjugated bilirubin. So reflection densities at the two wavelength 400 nanometer and 460 nanometer are used to determine the concentration of unconjugated bilirubin and conjugated bilirubin. So when we measure at 400 nanometer, both these bilirubin have similar molar absorptivity. Then we measure at 460 nanometer, Bu has higher molar absorptivity. So molar absorptivity at 460 nanometer indicate predominantly the concentration of unconjugated bilirubin. So from the molar absorptivity of 400 minus molar absorptivity of 460, we will get the molar absorptivity of conjugated bilirubin. That is how in our lab the unconjugated and conjugated bilirubin is measured. Total bilirubin as a modification of Vandenberg test, whereas Bu and Bc by measuring the molar absorptivity at 400 and 460 nanometers. So these two are two methods for the estimation of bilirubin. Other methods for estimation of bilirubin is direct spectrophotometric estimation. It is based on absorption of light by bilirubin near 460 nanometer. And that is mainly done in newborns where the predominant bilirubin is unconjugated. It is similar to the method which I described for BUBC microslides. But there the reflectance photometry is used. Here direct spectrophotometric method to measure the absorbance of light at 460 nanometer is used. And this method is mainly done to estimate the bilirubin in newborn where the bilirubin is predominantly unconjugated. Another method is HPLC. HPLC is high performance liquid chromatography method which separate and quantify for bilirubin fraction. Delta bilirubin, which already said the bilirubin which is conjugated with albumin. Then gamma bilirubin, which is the diconjugated fraction. Beta bilirubin and the monoconjugated fraction. Then unconjugated bilirubin. Then Z and E photoisomers of bilirubin. So these four bilirubin fraction value we get by performing the high performance liquid chromatography method. So a few words about delta bilirubin. The delta bilirubin is the bilirubin which is non-enzymatically and covalently linked to albumin. So in jaundice, when the bilirubin level is elevated, a small amount of bilirubin get non-enzymatically and covalently linked to albumin. In adults with prolonged cholestasis, especially if accompanied by renal failure, delta bilirubin fraction increases. Since delta bilirubin is not filtered by glomerulus, its half-life reflects that of albumin. The half-life of albumin is 3 weeks, roughly 20 days. So, since the delta bilirubin is not filtered and not cleared by the kidney, the amount of delta bilirubin in the serum that reflects the half-life of albumin. Hence, it remains in the serum or plasma long after other bilirubin esters have been eliminated. So, when the delta bilirubin remains in plasma, you will get a picture of conjugated hyperbilirubinemia in the absence of bilirubinuria. That is, in the urine, bile pigments will be negative, but when we measure the serum bilirubin, there will be persistent increase in the conjugated bilirubin. So, this persistent increase in conjugated bilirubin after the jaundice has cleared or after the bile pigments are negative in urine, and also when the enzymes has returned to the normal value, this persistence of conjugated hyperbilirubinemia indicate delta bilirubin. So, in our laboratory method, the delta bilirubin can be estimated as total bilirubin minus conjugated plus unconjugated bilirubin. Because in total bilirubin, it gives the value of conjugated, unconjugated and delta. In the estimation for conjugated and unconjugated, we get the value of Bu and Bc. So, total bilirubin minus conjugated plus unconjugated bilirubin, we get the value of delta bilirubin. Next, about urinary tests done in jaundice. In all cases of jaundice, the urine should be examined for the presence of bile pigments, bile salts and urobilinogen. The test for bile pigments in urine is the modified Fauchett's test. You have done in this abnormal constituents of urine, this test for bile pigments, the modified Fauchett's test. So, conjugated bilirubin is soluble in water, so it is excreted in urine. In obstructive jaundice, the conjugated bilirubin fraction is increased and urine contains bilirubin, so it is called choleric jaundice. It's a previous term, choleric jaundice, that indicate the presence of bilirubin in urine. Because in obstructive jaundice, the bilirubin which is elevated is conjugated bilirubin, bile pigments will be present in urine. Whereas in prehepatic jaundice or hemolytic jaundice, the unconjugated bilirubin is increased. It does not appear in urine and it is called acaloric jaundice. Unconjugated bilirubin fraction is not soluble in water, so it does not appear in urine. So it is this prehepatic jaundice is known as acaloric jaundice. And urine bile salts. Normally the bile salts are the sodium and potassium salts of primary and secondary bile acids, glycocholic acid or taurocholic acid. So these bile salts are present in bile, but they are not seen in urine. When there is obstruction in the biliary passages, there will be regurgitation of bile salts into systemic circulation, leading to its excretion in urine. So, in obstructive jaundice, the Hayes test will be positive. That is because there is, due to obstruction, the bile salts regurgitate into circulation and they are excreted in urine. So you have performed the test for bile salt Hayes test. It's a very simple test. You are sprinkling sulfur powder into the urine sample. If the sulfur powder goes to the bottom, then that indicates bile salts are present because bile salts lower the surface tension. So another urine test performed is test for urobilinogen. The urobilinogen in urine is detected by Ehrlich's test. When you mix the urine sample with Ehrlich's reagent, a pink color which is observed through the mouth of the test tube. So normally a mild pink color will be there. In obstructive jaundice, since bile is not reaching the intestine, urobilinogen may be decreased or urobilinogen may be absent in urine sample. In which type of jaundice the urobilinogen will be in increased amounts? That is in prehepatic jaundice or hemolytic jaundice. There will be increased urobilinogen in urine. And in addition to urobilinogen, the stercobilinogen also is not produced because of obstruction. So in obstructive jaundice, clay colored stools are seen. So that is a summary of urine test in jaundice. The test for bile pigments is modified Fauchett's test. In obstructive jaundice, in which conjugated hyperbilirubinemia is there, the Fauchett's test will be 3+. In test for bile salt, Hayes test. In choleric jaundice or in obstructive jaundice, it will be 3+. Then in Ehrlich's test, because of obstruction, bile is not reaching the intestine, so urobilinogen is not produced, so it will be negative in obstructive jaundice. Opposite findings are observed in prehepatic jaundice. In prehepatic jaundice, bile pigments and bile salts will be negative. Urobilinogen will be in excess amounts. Next, about the enzyme markers of obstructive liver disease. The first one is alkaline phosphatase. The normal value of alkaline phosphatase is 56 to 119 units per liter, and very high levels of alkaline phosphatase, about 10 to 12 times the upper limit of normal, may be seen in extrahepatic obstruction. Extrahepatic obstruction which may be caused by gallstones or by pressure on bile duct by carcinoma of head of pancreas. So in obstructive jaundice, the alkaline phosphatase value will be increased to about 10 to 12 times the upper limit. Why the alkaline phosphatase is increased is the isoenzyme of alkaline phosphatase produced by epithelial cells of biliary canaliculi. And when there is obstruction of bile duct, there will be irritation of the epithelial cell leading to increased secretion of alkaline phosphatase into serum. So that is why in obstructive jaundice, ALP value increases to very high levels. Due to obstruction, there will be irritation of the epithelial cell leading to increased secretion of ALP. Whereas in parenchymal diseases of liver, that is in hepatocellular jaundice, alkaline phosphatase will be increased only mildly. That is, if the alkaline phosphatase value is greater than 2 times the upper limit of normal, It will be obstructive liver disease. If alkaline phosphatase elevation is less than 2 times the upper limit of normal, it will be hepatocellular jaundice. That is how the abnormal liver function test in jaundice, that is AST and ALT, if they are greater than 3 times the upper limit of normal and alkaline phosphatase less than 2 times upper limit of normal, it is hepatocellular disease. Whereas if the enzymes AST and ALT less than 3 times the upper limit of normal and alkaline phosphatase greater than 2 times the upper limit of normal, it will be cholestatic disease. In cholestatic disease, whether to find out whether it is acute cholestasis or chronic cholestasis, serum albumin also can be measured. If the albumin value is normal, it is acute cholestasis. If the albumin value is decreased, chronic cholestasis. To find out the cause of cholestasis, intrahepatic or extrahepatic, ultrasonography or percutaneous cholangiography can be done. So apart from alkaline phosphatase, other enzymes which are elevated in obstructive liver disease is GGT. GGT is gamma glutamyl transpeptidase. So in liver diseases, GGT elevation parallels that of alkaline phosphatase elevation. So GGT elevation is a very sensitive indicator of biliary tract disease. In adults, the upper reference limit of GGT activity in serum is 40 units per liter for females and 70 units per liter for males. Similar to alkaline phosphatase, it is highest in intrahepatic and post-hepatic biliary obstruction. So in obstructive liver diseases, similar to alkaline phosphatase, GGT activity is also increased about 5 to 30 times the upper reference limit. And the other enzyme, which is similar to alkaline phosphatase and GGT, elevated in obstructive liver disease is 5' nucleotidase or ribonucleotide phosphohydrolase. It is a phosphatase enzyme. This nucleotide phosphohydrolase is increased 3 to 6 fold in hepatobiliary diseases in which there is an interference in the secretion of bile. So the assay of 5' nucleotidase or nucleotide phosphohydrolase activity is considered as an addition to the measurement of non-specific total ALP. That is, the ALP, if it is increased, non-specific total ALP values can indicate hepatic pathology or bone diseases. So if we assay the other enzymes along with alkaline phosphatase, non-specific total alkaline phosphatase, then they can indicate hepatobiliary diseases. In bone pathologies, these enzymes GGT and 5' nucleotidase will be normal, whereas if these two enzymes are increased along with ALP, that can indicate hepatobiliary disease. The reference interval of nucleotide 5' nucleotidase is at 37 degrees Celsius is from 3 to 9 units per liter with no sex-related differences. So these are the biochemical investigation which help to establish the diagnosis of obstructive jaundice and differentiate it from other causes of jaundice like prehepatic jaundice and hepatocellular jaundice. Thank you.